pancreatitis over the years. I just think it's it's got really neat functions, and we're going to talk about that. So it has endocrine and exocrine functions. So endocrine within those islets of Langerhans cells, right? What else do our islets of Langerhans do? Or why are they important? And diabetes, right? Because we may have impaired function of those islets of Langerhans. If we are not able to secrete insulin, what kind of diabetes do we possibly have? Type 1, right? Because it's an issue with the cells themselves. Not insulin resistance like type 2, type 1, right? But that insulin and glucagon is going to enter the bloodstream directly. That's our endocrine function. Exocrine, also releasing digestive enzymes. Okay, so it helps break down our dairy proteins. It helps break down starch and fats. Okay, and these actually enter into the small intestine. Okay, so your amylase, your lipase, okay, your proteolytics, trypsin, ribonuclease. Okay, amylase and lipase. Why are those important? Okay. Other than starch and fats. Has anyone ever heard of like an amylase and lipase level? Or seen them on patient charts? Yeah. Okay, so we can actually look at amylase and lipase levels to determine if a patient does have acute pancreatitis. Okay, those levels, typically they're very low, like 100, 500 here or there. But you're going to see patients with lipase and amylase levels in the thousands. Okay, that's how you're going to be like, okay, probably pancreatitis. Okay. But again, those digestive enzymes are going to enter into the small intestine. Okay, so how do we end up with pancreatitis then? The pancreas is going to try to digest itself, in a sense. Okay, so those digestive enzymes that are supposed to enter into our small intestine are now attacking the pancreatic tissue. They're not going where they need to go, or not doing what they need to do. That can lead to necrosis and actually hemorrhage. Okay, it's very dangerous. You can get acute pancreatitis, which we'll talk about, or chronic pancreatitis. But as you can imagine, if the pancreas is digesting itself, do you think that's pretty painful? Absolutely. These patients are in a lot of pain. Okay. Enzymes are typically secreted in an inactive form, which get activated within the intestine. But it can also digest within the pancreas. Inflammation within that causes direct obstruction, duct obstruction, and rupture of those ducts as well. Okay. When that happens, that's when those enzymes become activated and attack. Okay. So it's a process that is happening. So how do we get pancreatitis? Gallstones is a big cause. Because they cause that obstruction of the pancreatic duct, and it causes reflux. It's actually one of the main causes. So if someone has gallstones, they're very susceptible to pancreatitis. The bile, within the gallstones or the bile duct, can activate those pancreatic enzymes to cause digestion. Alcohol is a big one as well. So for people who consume alcohol, let's say, a big time you see pancreatitis is like 4th of July weekend. Okay, big drinking holidays. Think about stuff like that. New Year's. Okay, your patients may start having pancreatitis. Okay, because alcohol is going to cause the duodenal edema. So the duodenum is where? Think about your A&P. Okay. And then going into where? Goes into that portion of the small intestine, right? So it goes down and through there, and it causes spasms in the sphincter. Okay, so it can obstruct outflow from the pancreas over time. Okay, and then the pancreas is like, I'm not getting things out that I need to. My digestive enzymes are not getting out, so it's going to produce more and more enzymes. Okay, and it raises pressure within the pancreas. Very, very painful. Okay, to remember this, you can remember this acronym, GET SMASH. Okay, gallstones, ethanol or alcohol, trauma. Okay, steroids, mumps, which is a viral infection, autoimmune, scorpion, which is like poisons or toxins, right? That can cause pancreatitis. Hypercalcemia, and hypertriglyceridemia, ERCP, so that's when they go in to try to remove those gallstones, right? And then drugs, so immunosuppressants or chemotherapies are your big ones. So if you have trouble remembering some of the causes, that's a way to try to remember. Okay. So in the acute stage of pancreatitis, or the acute form, and it's an inflammatory process, due to activated enzymes that are breaking down the pancreas. Okay. This can range again from mild symptoms to that necrotizing hemorrhage. Okay. Chronic is a progressive destructive inflammation and fibrosis of the pancreas. Okay. So with alcohol use disorder, you're going to see, chronic calcification of the pancreas or chronic obstruction. Also, it could be autoimmune. You may not do anything to cause it, right? So it could be just your body attacking itself. Idiopathic, we have no idea what's originating it, right? We don't know why. Or hereditary. Severity of acute pancreatitis. So with mildly acute pancreatitis, we won't see organ failure. And the changes you'll see are more local or minor. Okay. These patients can typically be discharged within 3 to 5 days. Okay. But typically they're going to be in the hospital for management. Moderately severe acute, no organ failure or short-term failure of organs and local complications. And then severe acute is persistent organ failure for more than 48 hours. So that's how you kind of determine, is it moderately severe or is it severe? Okay. And then imaging, you may be able to see that pancreatic necrosis. Severe pancreatitis, what are we going to see? Hypovolemic shock, multiple organ failure, respiratory distress, and acute renal failure. Okay, so the body starts to shut down. Chronic, we're going to see gradual destruction of the pancreatic tissue. So over time, the pancreatic tissue is going to be destroyed. Okay. This is irreversible. Okay. Alcoholism is your primary risk factor for chronic pancreatitis. Now, malnutrition is one of the most common causes worldwide, so think about some of those underdeveloped countries. We may not know why, so if it's idiopathic, we don't know why. And there is an increased risk with cystic fibrosis because of lack of trypsin. Cystic fibrosis, we talk about a lot in the spring in 2030. So you don't have to necessarily focus on that one as much because you have a whole module of cystic fibrosis. Okay. So what are we going to see? Recurrent gastric and abdominal pain. Nausea and vomiting is a big one. Okay. If it's chronic, you might start to see some of that weight loss. Okay. Steatorrhea, that's that fatty, foul-smelling stool because we're missing those pancreatic enzymes because they're elsewhere, right? They're digesting the pancreas itself instead of where they need to be. Okay. Increasing episodes with shorter time in between. So we may have more acute episodes in our chronic state. Okay. Complications, we're not going to be able to absorb things as well, right? We need those enzymes to break down our food to be able to absorb the components. Okay, so we're going to have malabsorption, leading to malnutrition. Okay, we need those enzymes to help us break down our food. Okay, we can form abscesses, develop diabetes, right? Because we're going to not be able to secrete our insulin. Right? Pancreatic cancer and opioid addiction. Okay, so if they have a lot of acute flare-ups and a lot of pain, or if they're chronic pancreatitis, and they're taking pain medication, they can, become dependent. Okay. Assessment findings. So typically, especially with acute, you're going to have a sudden onset of severe abdominal pain. Okay. So if it's caused by alcohol, I went out for New Year's and I was just drinking a lot of alcohol, and then I woke up the next morning and I had severe pain, okay, abdominal pain. And then all of a sudden my abdominal pain is wrapping around my back, and I feel like I can't sit up, or I need to sit up because I'm in so much pain, okay? Because it does help to sit them up if they're in chronic, or if they're having an acute flare. Onset sometimes is exacerbated by fatty meals, okay? So sometimes they'll have you do like a diet recall. What were you eating before you had your acute flare up with your pancreatitis? Okay. Nausea and vomiting, that's a telltale sign. Abdominal distension, okay. Hypoactive bowels. Jaundice can actually be a result of this, right? And then tetany because of hypocalcemia, which I already talked about. But remember your trousseau sign and your Chvostek sign. Remember those from earlier in your nursing journey, right? So trousseau's is that hand spasm when you inflate a VT cap. And I've actually seen that before in a patient with pancreatitis. And then Chvostek's, if you're touching on the facial nerve, they do that twitching. Okay. How does everyone feel? You want to look at these? Do you need to see them? We're good. Hopefully a refresher. Okay. Diagnostics, this is in your book. Okay, we're back to the med surg book. Ultrasound's kind of your number one along with your CT, right? ERCP or biopsy. So we try to do least invasive first, right? So typically you're going to see them use contrast CT or ultrasound diagnosis. So what things are going to be elevated? Your amylase level. Okay, increasing within 2 to 12 hours, continuing for 3 to 4 days, okay, with your acute. Lipase is going to increase slowly, but elevated for up to 2 weeks. So which one do you think they base this on the most? Amylase, yeah, because you're going to have that increase within the first 12 hours, okay. White blood cells, why are our white blood cells, why are we looking at those? What's that?
Fighting it off.
Fighting it off. What else? What happens when we have an acute inflammation process? We have white blood cells increase, right? Because we're having inflammation. And your body's like, whoa, what's going on here? Something's wrong. I need to get it. Okay. AST, ALT, and bilirubin. So our biliary system can have some dysfunction. So we need to look into our liver enzymes and our bilirubin. We need to check glucose because if our pancreas is not functioning as it should, what's going to happen to our glucose? Yeah, they're going to go up, right? Because we're not secreting and producing insulin. Okay. Decreased levels are calcium and our magnesium. Okay. And also we need to look at our platelet levels. Okay.
Why would the magnesium be decreased?
Why would
magnesium be decreased?
It's similar to the calcium because those enzymes are binding to the molecules of calcium and magnesium. So it's kind of like destroying some of the calcium and magnesium. There's a ERCP procedure. If you have not heard or seen of that, I'll let you look at that in your own time. Here's a telltale sign of pancreatitis. Turner's and Cullen's sign. Cullen's sign, I don't know if you can tell, but this is the umbilicus. So you'll have a bruising discoloration around it. Okay. Turner's sign, that's like your patient's flank. Okay, bruising and discoloration. Okay. And it has to do with some of the digestion that's going on, changes in your coagulation factors, all of those things. So that's how we're going to kind of know that it's pancreatitis.
So both of these would be signs that
They have
vision types that way.
okay. Yes. So if you're calling your doctor and you're like, okay, their amylase level was this, and they're having extreme flank pain and radiating pain from their abdomen, and they also have Turner's and Cullen's sign, the doctors would be like, okay, they know what this is, right? Medications, opioids, right? This is an acute pain, severe pain. So hydromorphone, morphine, antibiotics if your pancreas becomes necrotizing. So if we've auto-digested so much that we need to give antibiotics because, we're having cell death and things like that. Pancreatic enzymes, so we can actually give pancreatic enzymes to help continue digesting food, right, in this acute state. So they stay within the digestive tract because they're oral, right, and we're able to still digest our food appropriately. Okay, we actually, this is huge in cystic fibrosis patients, right, because they don't produce trypsin and they need to be on pancreatic enzymes, because it helps break down. Okay. With the pancreatic enzymes, again, it's oral, so you sprinkle it on your non-protein foods, whether it's meals or snacks. Okay, and it's gonna help break down in those states. Chronic pancreatitis, they might need to be on those H2 blockers or PPIs, for reflux and things like that. Nutrition, they need to be NPO during acute episodes. Eating causes more pain to flare up because what happens when you eat? You're releasing more pancreatic enzymes, okay? So if your pancreas is trying to continue to release those enzymes, and it's gonna continue to digest itself, so we need to take a break from eating orally, okay? Because the pancreas is already overactive. Okay. Sometimes we'll put in like NG tube to try to prevent that. Okay. IV fluid or TPN if it's going on for a long time and we need to start some nutrition. Okay. You may be able to resume by mouth feedings when those amylase levels are normal. Okay. We said they may have hypoactive bowel sounds, as long as the bowel sounds are present and active, you can resume eating. Okay, but that pain needs to be more resolved before we start. Is everyone following me so far? Okay, so our surgical options, again, do this video for ERCP. We can also do cholecystectomy if it's gallstones is our cause. Okay, it kind of just depends on why we're having pancreatitis, right? So if it's alcohol induced, we need to remove that. Right. And we need to make sure that we're not, causing more damage with our consumption of alcohol. Okay. Nursing care. So again, our priority is to keep them NPO. A bland diet high in protein. Okay, because remember, fatty diets, we secrete more of those pancreatic enzymes, right? We said sometimes those high fat diets can send you into acute pancreatitis. We don't want that. We need high protein, low fat diets. No stimulants, coffee, that's a big one. Okay. Small and frequent meals. Okay, when we first start initiating food after being NPO. Okay, so these patients, they're NPO for like a few days. They start eating and they want everything, right? They're like, I want this fatty food and this fatty food, and you have to be the one that says, oh, actually, you need some bland foods, and they're not very happy with it. But it's very important for our nursing care. If they need, we may have to give them an NG tube to help decompress the stomach, right, at first. We need to make sure they're not drinking alcohol to upset this further, or smoking. Those are huge for preventing worsening pancreatitis. Antiemetics, so again, they have a lot of nausea and vomiting, they may need antiemetics. Okay. And some form of analgesia. Probably see morphine most common, or even Dilaudid. It's pretty painful. Monitoring their glucose. Okay, because remember, those cells are impaired. Hydration, keeping track of their INOs, and reducing stress. Stress is very harmful when it comes to pancreatitis and making those flares worse. Okay. So teaching them how to prevent further attacks, right? No alcohol or smoking. Okay, stress reduction at home. Diabetic education, if there's permanent damage to those cells in the pancreas. Low fat diet they want to maintain. Okay. Avoiding crash dieting, so sometimes they'll try to crash diet and then all of a sudden they're eating all these things they shouldn't be, right? Avoid spicy foods, chocolate and caffeine. So coffee, chocolate, anything with caffeine in it, don't drink your Alani energy drinks anymore, right? Those have a lot of caffeine in them. Reporting signs of infection, because that could be a sign of an abscess forming. Okay. Let's try the practice. So the nurse is completing an assessment on a patient with acute pancreatitis. Which of the following is the priority to report? What do you guys think? We can chat it out.
D.
D, hypocalcemia can cause EKG changes, so think about concerning things that could be happening, right? And it's concern for hypertension. Okay, so A, cholestasis, okay, so that's a risk for obstructive pancreatitis, but it's not necessarily a priority, right? Because it could be other things. Increased amylase is expected, right? That's an expected finding. And then the patient could be at risk for ileus because of those high vowel sounds, slowing down in motility, but it's not necessarily priority. B is your priority. Okay. Which of the following actions should the nurse take to assess for Cullen sign? That's right. Because one way to remember this is Turner's sign. You have to turn them to left, right? So Turner's is on your flank. Cullen sign is around your hips. Good. Nurse is completing nutrition teaching for a patient with pancreatitis. Which statement indicates understanding? This is a select all. Are we going to do small frequent meals?
Yes.
Yes, very good, right? How about, that should be easy, sorry, I'm trying to do this at night. Easy to digest foods with limited spice. Yes. How about, I will use skim milk when cooking.
Yes.
Yes, the skim milk is actually lowering blood fat, right? Good. D, I plan to drink regular cola. No, because cola has what? B, and I will limit alcohol to 2 drinks a day.
No.
No, because is that too much?
Yes.
Yes, right, you wanna cut alcohol. Okay, we're gonna touch on pancreatic cancer. So pancreatic cancer is the 4th leading cause of cancer deaths. Okay. November coming up is actually Pancreatic Cancer Awareness Month, so we're getting there. The 5-year survival is only 6%, so it's an extremely aggressive form of cancer. Okay, and I say I like pancreatitis. I had a lot of patients with pancreatic cancer working on oncology. So the incidence of pancreatic cancer does increase after age 50. Men are more common to get this than women. And African Americans are more common to get this rather than Caucasian. A lot of patients that I see, or I've seen with pancreatic cancer, there's actually studies going out about some of those weed killers and things like bug sprays around your home that can actually be contributed to some pancreatic cancer. So what gender typically does all that kind of stuff? Everyone else, right? So things like that can predispose you more for risks, you know, occupational health hazards and things like that. Okay. Risk factors, smoking, 2 times higher of a risk than non-smokers. If you have chronic pancreatitis, you're more at risk. Diabetes, liver cirrhosis, obesity with high fat diet, genetically linked, and then a lot of times your pancreas, it's a metastatic process from another area. So you have a diagnosis of a different type of cancer and it metastasizes to your pancreas. So what will you see? So usually you don't have as many symptoms until a later stage. Okay, so you may have pancreatitis, But it doesn't usually get diagnosed until in its later stages, and hence why it's less survivable and slow, right? Because it's diagnosed later. Fatigue, anorexia, and itching are your big signs. Weight loss, okay. That epigastric pain and radiation, so think about some of those pancreatitis signs, okay. Later signs, you're gonna see jaundice and ascites. Clay colored stool, because we're gonna start to have some liver involvement. So palpable mass to pancreas, okay, or to the liver, and then hepatomegaly and bowel infections. Okay. Diagnostics, again, ERCP, biopsy of the pancreas. Okay. Sometimes they'll do a paracentesis if you start to develop ascites. Okay. I have your tumor markers listed there. They're gonna do serial CT, MRI, and PET scans to see kind of how things are developing over time, possibly an endoscopic. To treat pancreatic cancer, chemo and targeted chemotherapy. Okay, so targeted chemotherapy or targeted therapy is trying to interfere with those molecules with cancer-causing genes. So this is kind of like your new gene therapies and things that they're doing. Targeted radiation, okay. Surgery, so open or laparoscopic. Okay. Surgery can be potentially curative or palliative. So palliative for pain, right? So we know it's not going to fix your cancer, but it may make it a little less painful, right? Most commonly, you'll see the Whipple procedure. Who watches Grey's Anatomy? We love a good Whipple, right? So pancreatic duodenectomy, removing parts of the pancreas, the intestines, nearby lymph nodes, gallbladder, bile duct, and sometimes parts of the stomach. It's a lot, right? And that's why they say, oh, you got a Whipple, right? Because they're doing a lot of different things within that procedure. Okay. Stent placement, keeping the bile duct open from cancer compression. Okay, so hopefully by keeping that bile duct open, we're not going to lead into pancreatitis or issues with the liver. And then bypass surgery, so rerouting some of that bile flow. Okay, here's a picture of your Whipple. Okay. So as you can see, there's a lot of different things going on here.
What if the tumor's on the other side?
What's that?
What if the tumor's on the other side?
They may not be a candidate for it. It's very specific.
So the Whipple is just for the tumor on that side?
It could be. I think it just kind of depends too on what they're willing to do with it, because it is a very invasive and high risk procedure. So a lot of people don't qualify for it. So it's very specific to, what they're able to do with wherever you're doing. Okay, let me talk about nursing care and then I'll play one video for you. So nursing care. A lot of our care for cancers is, it's a lot of psychosocial care and reducing fear and anxiety and associated with that. We need to keep them in semi-fowlers to help facilitate lung expansion, because remember, they may develop ascites and things like that. So we need to set them up to help expand lungs. And G-tube, we need to monitor their drainage every 48 hours. Pain control, PCA pump, infusions are as needed. I've had many a hospice patient pass away from pancreatic cancer. It's a very invasive and severe type of cancer. And pain control is your number one, right? Promoting oxygenation. They may need enteral feedings over time, monitoring their glucose and monitoring for any hemorrhage from, necrotizing other pancreas, shock, or peritonitis. Okay, let's do a survivor story.
And I'm a pancreatic. Hi, my name is Kim, and I'm a pancreatic cancer survivor. But that's not really who I am. I'm more than that. I'm a wife, I'm a mother, and I'm a friend. This is my story. October 2010, I went to my doctor's. I just have stomachache. So they sent me to the gastro guy, said there's something there. Let's just send it over just to be sure. It's 99% nothing. but I have to be sure. Going to Penn, they made me very, very comfortable. And he did the test, I was out of it. I get up and the results come back immediately. And he says, I'm sorry, you have pancreatic cancer. I turned to my husband and said, we're gonna beat this. No matter what happens, we are gonna beat this. With pancreatic cancer, usually where they try to operate, if you're not operable, you're not cured. You have to get to that surgery table to be cured. And when I was first diagnosed, my tumor was wrapped around blood vessels and arteries, and they could not operate. So the goal was to shrink the tumor. I chose Penn's Abramson Cancer Center because they had the trial. They had a trial protocol that I fit into. It was a little more rigorous, it was a little more intense, and it was gonna make me a little more sick, but I thought it would be worth it. And now I was in for a long journey. So now I had radiation and chemotherapy that I wore 24 hours a day. And with that, once a week, for I believe 6 or 8 weeks, I had the other 2 drugs, part of the chemotherapy, to get me, to enhance everything that I was getting, and hopefully it would shrink. So I called the surgeon at Penn, and he says, Kim, you're operable. Unfortunately, with pancreatic cancer, it's a nasty one. It has a tendency to possibly come back. In July, we found it. August 1st, I started another protocol with Penn. Only this time, because technology is changing daily, weekly, it's changing so fast that now they can offer me protons. Dr. Metz, my radiation oncologist, said, we're gonna get this. He said, this is nothing. This is just little, it's nothing like what you had last time. And anyway, make a long story short, today I'm cancer-free. You need to be someplace that's going to treat your cancer. Penn treated my cancer. It didn't treat pancreatic cancer. It treated my pancreatic cancer. They offer the doctors, the support staff, the technology, the drugs, the treatment. But the cure is within you. I am the one that has to stay focused. I am the one that has to fight the disease. Penn is there to help. Penn is there to do whatever we need for our cancer, but the cure is within.
So not every facility in place offers the same cancer treatment, right? There are things coming out, and some patients have to travel to, research hospitals and teaching hospitals and some of those larger organizations if they want more radical treatment, right? But that's how we learn and we come up with new ways to treat things, right? So if you stay local, if you're in a smaller hospital system, you may not see some of these other treatment options, right? It just kind of depends on what they're comfortable with doing. So keep that in mind as well. If you plan to go to like a large system, research hospital, you might see more, procedures that are new and exciting and things like that you haven't heard of before. So it all kind of just depends on where you're at. So any questions from today? It's a lot of content, so try to break it down. It is going to be included on your next exam. So you'll get a testing plan that kind of lays everything out today. We talked about it this morning. So, try to keep in mind we base it off of how many hours are spent on each subject area. So if it's got a lot more time devoted to it, then it's going to be tested on more so than something that you only covered, for a little bit more. So keep that in mind as you're studying. But we'll get that out to you as soon as we can today, and I'll try to get some clarification on your trait testing. Okay.